Well, hello everyone, and thank you for joining us for this Rural Health webinar today. It's my pleasure to introduce our speaker for today, Dr. Benjamin Jones. The title for today's webinar, as you can see, Multiple Sclerosis for the Non-Neurologist. The goal of our webinar today is to focus on MS, in particular for those that are, again, as you see the title, not neurologists, but those that are medical professionals or just a layperson wanting to learn more about MS. Again, it's my pleasure to introduce Dr. Benjamin Jones, our speaker. He is an assistant professor in the Division of Neuroimmunology and Multiple Sclerosis in the Division of Neurology at the University of Alabama Birmingham School of Medicine. He's an attending neurologist at the UAB MS Clinic, also serving as co-director and attending neurologist for the UAB Transverse Myelitis Association Clinic. He was born and raised in Birmingham and received an undergraduate degrees in biology and psychology at at Birmingham Southern College before attending the University of South Alabama College of Medicine. He returned to Birmingham for residency training in neurology at UAB, and on completion of his residency pursued a 2-year fellowship in MS and neuroimmunology at UAB, joining the faculty upon completion of his training. In addition to his patient care roles, he also serves as the ambulatory medical director and quality officer for neurology. Mentors first and second year medical school students at clinical sites as a clinical skills scholar, teaching neurology students and fellows, and participates in clinical trials for MS and other neuroimmunological disorders. Dr. Jones, very much a pleasure to have you on the call today, and thank you and your team for putting this together, and the floor is yours.
Thanks very much, Ryan. So this will be a little bit of a kind of high-level overview of MS. I was trying to not get too much into the weeds into anything so that hopefully everybody who's attending and joining today will have get something out of this. If you do have questions or anything along the way, feel free to drop them in the chat. And if I happen to notice it, I'll try to address it then. Otherwise, we'll try to get to it at the end. Um, so just as where are we? Where's this? There we go. So basic objectives today, just kind of an overview of MS, as well as how we manage MS, and then some of the common issues that come up when you're treating people with MS, whether the problem that you're trying to address is directly related to MS or not. Um, and so kind of at the very basic here, what is multiple sclerosis? So MS is an inflammatory condition that affects the central nervous system, so brain, spinal cord, optic nerves, that at a pathological level results in demyelination, so loss of the insulating coverings of the nerves. In more severe cases, you can actually cause damage to the neurons themselves, so you can end up with loss of neurons. And then ultimately, you end up with neurodegeneration, so just gradual loss of neurons and brain tissue over time. Clinically, what we see is that these folks with MS are going to have what we call episodes of neurologic dysfunction that are separated in time and space, meaning that you have multiple episodes over time and then multiple areas of the central nervous system can be affected by MS. Up until the last couple of years, I guess that paper was published, what, 3, 4 years ago now. The kind of number that we've quoted for a number of years is there was about 450,000 people in the US that have MS. It turns out we were wrong quite substantially. And the current estimate is that we have somewhere close to 1 million people living with MS in the United States currently. You can see that the rates of that are somewhat higher in the northern latitudes, both in the US and then globally as well. You see that MS is more prevalent the further away from the equator you get. In the US, we're seeing the prevalence of MS increase at about 6% per year. Some of that's because we're better at diagnosing MS. Some of that's because people with MS are living longer than they used to. It's a female predominant disease, about 3 to 1. And based on the data that we have now, it's a predominantly Caucasian disease, although we see it with increasing frequency in non-white populations. The differences that we see in prevalence among racial groups are probably not as big as we think they are because we're just underdiagnosing it in some of these minority groups. We're one of the most expensive reasons for healthcare in the US currently. MS is right up there with things like chronic kidney disease and dialysis. Most of the cost of MS is related to the drugs that we use, which is about $30 billion a year, and that was in 2019 numbers. Our annual treatment cost for the treatments that we use is typically exceeding $90,000 and in many cases now is exceeding $100,000 a year. The short answer to the what causes MS question is we don't know. The longer answer to that question is there's probably multiple things at play here. There's been a number of genes associated with increased risk of developing MS. There is increasing evidence that exposure to the Epstein-Barr virus probably is doing something to provoke some sort of immune response that eventually leads to developing MS. There's some evidence as well for vitamin D deficiency, and then just general dysfunction of the immune system, causing it to become overactive and begin to attack the nervous system. Some common misconceptions that hopefully by the end of this we will have dispelled about MS is that MS always causes severe physical disability, that there's no treatment for MS, only young people get MS, and that MS is fatal. All of those things are happily not true. So if you go to the MS Society's website, and I love them, but I wish they would change this. If you go read the signs and symptoms of MS, you start reading through it, and then you start beginning to wonder if you yourself might have MS, because the list of symptoms that MS can cause is just humongous. And so we'll come back to this in a bit. The real key, though, is how you experience those symptoms when it comes to raising our suspicion for MS. So the basics of how we diagnose MS is that somebody has to have experienced what we call a typical demyelinating event, and come back to that in a minute. We have to show that there are multiple areas of the nervous system involved. That's the dissemination in space part. We have to show that there have been changes over time. We have to rule out everything else that we think might be causing these symptoms or findings on a patient's MRI. And currently, we do that from criteria that were published back in 2017. At the end of the day, MS is a clinical diagnosis. We have some guidelines and some criteria for how we should be doing that. But there is no one test that we can do that says you do or don't have MS. So at the end of the day, it becomes a clinician's judgment. So that typical demyelinating event, you hear this go by a number of names, things like attack, episode, exacerbation, flare, relapse, to name a few. But the way that we define a demyelinating event is that it's a monophasic episode. So somebody is going to come in reporting some sort of symptom that we can somehow find on their neurologic examination, and we can localize that finding to the central nervous system. Usually this is going to be a single location in the central nervous system, but sometimes you can have multiple areas involved simultaneously, which can make it extra confusing for those of us trying to figure it out. Something that's acute to subacute in onset. So this is, I wake up one day, my hand feels a little numb, a little tingly. I slept on it wrong. Go about your day. Later in the day, it's still there. Maybe it's a bit worse. And then the next day, I'm having trouble holding onto my coffee mug and my hand's definitely still numb. Something that kind of comes on over the course of hours to days. These symptoms have to be present continuously for at least 24 hours without a fever or an infection. And then at some point, there will be some recovery. That may be complete recovery, it may be incomplete, or it may not recover at all. And so some of those more common presentations would be things like optic neuritis, various brainstem syndromes where you can have facial pain or numbness like trigeminal neuralgia or trigeminal neuropathy, eye movement abnormalities, the classic one being the internuclear ophthalmoplegia, which we'll show you a picture of in a minute. Ataxias, so tremors and coordination, things like that, and then transverse myelitis. So optic neuritis is typically going to affect one eye. This is going to be some inflammation in the optic nerve behind the eye, carrying all the visual information from the eye to the brain. Classically, these folks are going to complain of colors being darker. They're usually going to have like a piece of vision missing, kind of usually in the center of their visual field. when they have kind of low contrast situations. So like dawn, dusk, when everything's just kind of shades of gray, they'll have trouble distinguishing those low contrast situations. Decrease in visual acuity. So there's typically going to be blurriness to the vision. They're not going to be blind, but reading the sign on the wall to tell you which office to get to in the clinic may be a challenge. And then they'll have this thing called an aberrant pupillary defect. The fun one that we always like to test the students on because it's a nice, easy piece of neuroanatomy, but also is a fairly common finding in MS is the internuclear ophthalmoplegia, where people are going to have horizontal diplopia, so they'll have double vision when looking to the side. And basically what happens is in this patient, for example, this person's trying to look to the right, and their right eye goes on to the right, but the left eye doesn't follow. And so they end up with double vision. And the other common one is transverse myelitis. So this basically just means inflammation in the spinal cord. But again, you're going to have this subacute onset of symptoms over the course of hour to days, where people are going to have some combination of decrease in strength and sensory changes, usually affecting one side of the body a little bit more than the other. They're very commonly going to have complications with bowel and bladder dysfunction. And then on imaging, we define these lesions as being what we term short segments. So they're going to be less than 3 vertebral body segments in length. You can see the little white spots in the spinal cord examples over here. And you can start a fight at an MS meeting with this, but broadly speaking, we have 3 types of MS. We have relapsing remitting, which is far and away the most common presentation of MS. It's about 80 to 85% of people who present with MS, where you going along, you have some neurological symptom, your optic neuritis, your transverse myelitis, whatever it is. It's there for a period of time. It gets better. Sometimes you completely return back to your baseline, as in this upper panel on the left. Sometimes you don't, as in the bottom panel, and you're left with some fixed neurologic deficit, numbness, tingling, weakness, what have you, whatever it may be. If you go along long enough with relapsing remitting MS, you will eventually develop what we call secondary progressive MS, where the relapses, the kind of acute new symptom development kind of fades away, and then you have mostly this gradual worsening of neurological function over time. Mostly that takes the form of gradually worsening spinal cord dysfunction, so balance, walking, and bowel and bladder function. You can still have relapses thrown on top of that, where you can still have some inflammatory activity, but most of what's happening here is neurodegeneration. The other common presentation for MS is what we term primary progressive MS. So this is the person who shows up with just gradually worsening symptoms. They have imaging features and laboratory findings consistent with MS. In reality, these are all kind of the same thing. We're just capturing them at different points in time. And so one way to conceptualize this is you have this dotted line, which is some threshold that the spot in the brain has to reach to cause you to have symptoms that you notice. If you have 2 of those, we start calling you relapsing MS, but in the background, you'll have some other little bouts of inflammation that maybe don't reach that clinical threshold. Those are the changes on the MRI that we would see if we do follow-up scans on somebody. Each of those little gold bars is basically an individual bout of inflammation. But in the background, what's happening is each time you have one of these little bouts of inflammation, you get a step up in loss of neurons, which outwardly appears as disability, permanent numbness, permanent weakness, balance problem, what have you. And at some point, that neuron loss, that disability accumulation stops being stepwise and becomes gradually progressive. And at some point, it crosses that threshold, and we call it progressive MS. In the background, before it hits that threshold, we don't necessarily see outward signs of that. But what we do know is that if we look at the brains of people with MS, they start shrinking faster than the average person. And eventually that becomes clinically apparent with progressive MS. So we've diagnosed somebody with MS. Somebody has, possibly me, maybe somebody else. And so now we need to do something about it. So there's really 3 primary ways that we think about treatment for MS. The first is treating those acute relapses when they do occur. The second is long-term treatment to modify the disease course. And then honestly, where we spend the most of our time is symptomatic management, dealing with the symptoms that MS has caused, and trying to deal with them in the most effective way that we can. So relapse treatment, the first kind of step here is this something that we really think is new symptoms related to MS, or is this somebody's old symptom that has gotten worse? And so that's really kind of our first step. This little flow chart that you see on the right is something that we put together for our urgent care and ER, to try and give them some guidance on how to approach our patients when they happen to show up complaining of new or worsening symptoms. So if somebody's got, old symptoms that have kind of suddenly gotten worse, that's most likely going to be what we term a pseudo relapse. So that's typically caused by most commonly, it's going to be a urinary tract infection or other infection. But really, any kind of physiologic or emotional stressor can bring out the old symptoms of MS. So somebody who had, for example, an optic neuritis a few years ago, their vision has returned to more or less normal. If you go stick them in a sauna, or for that matter, just step outside today for a few minutes, that visual loss may become more noticeable because their body temperature's gone up. If you give them a cold, you give them the flu, you give them a urinary tract infection, those visual symptoms are going to worsen while they're sick. Once you remove the stressor, the infection gets treated, they cool off, they rehydrate themselves. Those symptoms should kind of go back to where they were before. What we're really concerned with, though, is somebody's got some new symptoms, so new numbness, weakness, tingling, whatever it may be, vision loss, balance problem. If we can't find something that seems to be causing that besides MS, our first step is typically going to be steroids. Um, if it's something relatively mild, not very bothersome, we can do nothing about it and just let it get better of its own accord. If somebody wants to make it get better a little faster, we can give prednisone by mouth. If it's something more severe, you can't see, you can't walk, can't use your arm, whatever that may be, then we'll typically move to IV steroids. We will typically do that through home health for our patients, rather than bringing them into the hospital. Because most of the time it can be handled at home. Although if somebody can't walk, can't see, can't be taken care of at home, then we'll admit somebody to the hospital to get those steroids if need be. Um, but really anything, it comes up a lot for us, for our patients, particularly with the lack of neurological care in my case, Alabama, and to some degree, Mississippi, where a fair number of our patients travel from. But I think most places, particularly in the Southeast, where you have kind of a lack of neurological care available that's nearby, um, it ends up falling, I think, a lot of times to the primary care physicians and the primary care teams and emergency rooms when these people show up. And it's, my rule of thumb to patients is always, if you have some new symptom or some old symptom that's suddenly become much worse, you need to look for the reason why, because it's unlikely that your MS has suddenly caused your old symptom to become worse. And so really thinking through, is there some recent sick exposure? Have you been out in the heat because it's baseball season and your kid plays baseball and you've been sitting at the ball field for 6 hours a day in the sun? Those sorts of things. It only takes a half a degree change in core body temperature to make somebody's MS symptoms worse. And this time of year, that's going to be a lot more than a half a degree core body temperature just walking to your car to and from Walmart or something. And then, so we've treated the relapse, we've given them their steroids. We need to do something to control their disease over the long term. And so we have a variety of drugs that we use to do that. The disease modifying drugs that we use don't, they have limitations. They're not perfect. What they can do is prevent future relapses. When we treat people early, we can delay the onset of progressive MS. And we can prevent more disability from accumulating, permanent neurological symptoms from accumulating by preventing some of those relapses. What we don't do with these drugs, though, is address the symptoms of MS. We don't reverse the symptoms of MS, and we don't repair the damage that's been done by MS. What I tell my patients is, I'm giving you this drug. You're probably not going to notice anything from it, but my goal is that by starting this medicine for you, you basically will remain the same as you are today for as long as possible, ideally indefinitely. But the reality would be we're going to minimize the chance of you developing new symptoms from MS by giving you this drug. I'm not going to make you feel better. I may give you some side effects by doing that, but the goal is really stability rather than improvement with these medicines. That doesn't mean that we can't try to address the symptoms that they have in other ways, but the drug I give you to treat MS is not going to address your symptoms. So what does it actually do when we give people a drug to treat MS? Basically, we reduce the number of these episodes of inflammation, these relapses, the new spots showing up on the MRI. And we push that progression and neuronal loss further out into the future. So what we know is that if we treat earlier, we can delay the onset of progressive MS. We may not avoid it entirely, but what we can do is push it further and further out into the future. Um, and then realistically, if you look at the untreated groups of people with relapsing MS, by 20 years, 95% of them will have developed secondary progressive MS. And so by treating them earlier, we can hopefully extend that window of them developing secondary progressive MS because our treatments at this point don't do much for progression. They treat primarily the relapsing phase of the disease. And so by pushing that progressive phase further into the future, hopefully that's happening when they're in their 60s, 70s, and 80s, at which point, you know, we're not so worried about it because we got bigger fish to fry because they're in their 70s and 80s and they've developed, hypertension and diabetes and heart failure and all of these other things that are probably going to be, hopefully, will be the bigger problem more so than their neurological condition. So what do we have for this? So the first drug to approved to treat MS was beta-seron, was approved in 1993. And since then, we've ended up with all of these, and we've gotten even more complicated because we have generics and biosimilars available now, which further complicates matters when dealing with insurance companies. Um, and so I lost count of this, but I think if you include all of the generics, we're up to like 26, 28 different approved medicines to treat MS these days. There was one that was pulled from the market, Zenbrida, back in 2018 after some infection complications became a bit of a problem. Um, but this kind of spans the whole spectrum. We have pills, we have shots, we have infusions, and a variety of different mechanisms of how they work. When you start looking at the mechanisms of how these drugs work, it becomes clear that we don't exactly know what we're doing. We don't know exactly what's going on with the immune system necessarily that's causing MS to happen. But we do know that these drugs work, and they work well to treat MS. So we have drugs that kind of modulate the immune system. They kind of just put the brakes on things and tell it to slow down. Those are generally thought of as being the somewhat less aggressive treatment options. Um, and most generally speaking, some of the older treatment options like beta-seron and others, you have drugs that kind of stop white blood cells from going places. So you've got Tysabri, which has been around since the early 2000s, which is a monthly infusion. And then you have the various versions of Gilenya and its cousins because the drug companies have started tweaking molecules and trying to make them better. Um, you have drugs that just get rid of white blood cells. It turns out we can basically just wipe them out and you'll be reasonably okay. So we have drugs like Lemtrada, which gets rid of both B and T cells, and then allows them to kind of repopulate. And then we have drugs that target primarily B cells. Um, these are all the top three there, the Ocrevus, the Kesimpta, the Briumvi are all monoclonal antibodies, and Mavenclad is an old chemotherapy drug that has since been repurposed for MS. Um, there's a lot of debate about which of these drugs we should be using, how we should be using them. To date, there's no consensus guidelines for us on what's the right drug to use for the right person in the right situation. And so it's a lot of just kind of feel, and I think this seems right for this particular person because of their risk tolerance for side effects, because of their disease characteristics, and in all honesty, where they live and can they come to an infusion center or not. Um, I have folks who are coming from all the way down at the Gulf Coast, Florida Panhandle. I have folks coming from most of Mississippi, bits of Western Georgia. So putting them on something like Tysabri that's given in an infusion center once a month is just not practical in a lot of cases. Um, and realistically, I'm sure you've all seen the commercials for Ocrevus. Twice a year sounds great. It's really convenient. Which is, I think, what drives a lot of my prescribing for that is people just like the idea of things that are convenient. Um, so I find myself doing that a lot, mostly because of the distances that our patients have to travel. Kind of our general pitfalls with the disease modifying therapies. All of these drugs are affecting the way the immune system functions in some way, shape, or form. And generally speaking, that is kind of suppressing the immune system in some way, shape, or form. So we are increasing infection risk. In most cases, that is kind of your run-of-the-mill, your cold, flu, upper respiratory, sinusitis, urinary tract infection. It's typically not serious infections. Although that can occur, you can sometimes end up with some more unusual infections, viral infections, fungal infections, things like that. Those are rare, they do occur, but generally speaking, it is just run-of-the-mill kind of things. For most of our drugs that we're using these days, particularly the higher efficacy drugs, we do have to be somewhat cautious with vaccinations, particularly your live and attenuated vaccines, because of the way some of these drugs work, and the way that they affect the immune system. If we give folks live or attenuated vaccines, they can potentially just get that infection. And so we tend to avoid a lot of those during treatment. And then the big elephant in the room that scares a lot of people is progressive multifocal leukoencephalopathy, PML. Um, it's there have been cases of PML with most of our newer MS drugs. The big one that kind of brought this to the fore was Tysabri, which was actually pulled from the market temporarily while they did some further investigations to kind of figure out risk stratification and how we can predict risk. But pretty much all of our MS drugs have had PML cases associated with them. Most of those numbers are, in the single to low double digits out of hundreds of thousands of people treated. Um, but it's something that comes up as a concern from patients fairly frequently. Um, I tell everybody PML is my job to worry about, not yours. I want you to worry about just going and doing your thing every day and living your life. I'll worry about the scary side effects for you. Usually that works. Sometimes it doesn't. Where we spend the most of our time, though, once we get somebody on treatment, whatever that drug may be to treat their MS over the long term, they will generally remain on that treatment indefinitely. Sometimes we'll have breakthrough disease, side effects, whatever that prompts us to need to change their disease modifying therapy. But generally speaking, it's kind of set it and forget it. You get it going and they just keep taking it. You do your monitoring labs, you do your MRIs periodically to make sure that it's doing its thing and they're not developing subclinical disease activity on MRI. And so most of the time in clinic is spent dealing with just the symptoms. And it's, you know, all manner of things. You can see here you've got numbness, tingling, cognitive dysfunction, depression, fatigue, spasms, weakness, bowel and bladder dysfunction, pain, vision problems, dizziness. Basically, think of any neurological symptom that you can imagine, and you can probably have it in relationship to MS. And so it's a little bit of a game of whack-a-mole. My rule of thumb, generally speaking, is when somebody shows up to me with some new symptom, I want to make sure it's not other things first. What happens, the kind of cognitive bias, I guess, that we often run into is, MS can cause any number of symptoms. This person has MS, so this symptom probably is related to MS. And that's not an unreasonable thought process. But you also, I think it's always a good idea to do just some basic due diligence to make sure that that symptom is not due to something else. Pinched nerve, you know, I had one patient, people talk about the MS hug, that tight sensation around the chest or waist that people with MS can get. And I had this patient who, had this tightness in his chest. Um, and everybody was like, yeah, that must be an MS hug. And, he came to see me and I started asking some more questions. I only get this when I'm walking up the stairs and it goes away once I start resting. And I'm going, okay, that sounds a little bit cardiac to me. That's a little concerning. So I made him go see a cardiologist, and it turned out he needed a stent. So that's an extreme example, but just because we have MS doesn't mean we're immune from having other problems too. Kind of going through some of these symptoms and how we try to address them. Fatigue is probably my biggest frustration, and I think many patients' biggest frustration as well. Half of people with MS will say that fatigue is their most disabling symptom. And 90% of people with MS will experience fatigue at some point in the course of their disease. And it's one of the leading causes for people with MS to leave the workforce and to end up on disability. It's not because they can't walk, because they can't use their hand, because they, have cognitive impairments. It's because they just are exhausted all the time. Um, and we don't have fantastic ways of managing it. The best evidence that we have out there is that behavior modification, aka take a nap and rest occasionally, is the best way to manage fatigue, which, people who have kids and a job, you can't just say go take a break every once in a while. That's not really that feasible for most people. But we do encourage people to try and be smart about how they're expending their energy. If you go hard this weekend, you're probably going to be struggling on Monday, and you're probably still going to be struggling on Tuesday. You need to make sure that you're getting adequate rest. We need to make sure that the sleep that you are getting is good. You don't have sleep apnea that we don't know about. Because if you do, we need to treat that problem. Most of the way that we address fatigue in people with MS is kind of chipping away at the edges and looking for anything else that might be contributing to that fatigue, and then trying to treat that problem and then see where we are. Exercise has good evidence for improving fatigue in people with MS. And if all else fails, we start prescribing stimulants. That is, if I can, my last option. Pretty much all of the evidence that's out there is that, treating fatigue with stimulants like Adderall, Ritalin, modafinil, Provigil, things like that, mostly results in increased side effects and adverse events and doesn't really change, at least the way that we measure fatigue in clinical trials, the scores on fatigue in the clinical trials. That being said, there are some people who definitely benefit from stimulant medications. I just try to avoid them unless we really need to. Bladder dysfunction is always at the top of the list of bothersome symptoms for people with MS. It makes sense. If you can't control your bladder, you're having to pee all the time, life's hard to live. If you're constantly on the lookout for where the next available toilet is, it's hard to have a good time when you're out to eat or going shopping with friends and family, whatever, on vacation. And the other problem is having bladder dysfunction because of MS tends to increase risk of UTI. So when you're not fully emptying the bladder, you tend to get more urinary tract infections. So there's kind of two broad um, patterns of bladder dysfunction in MS. The most basic is just increased urinary urgency and frequency, with or without incontinence because of that. That typically will respond to medications, your typical antispasmodics, your myrbetriq, your tamsulosins, things like that. In more difficult cases, we'll end up referring to urology because they can do a little more in terms of management. They can also do Botox to the bladder itself to reduce some of that urgency and frequency. The most challenging bladder dysfunction is when the bladder muscle and then the sphincters muscles are not working in concert. So the bladder is trying to contract to expel the urine, but the sphincter hasn't relaxed. And so it's basically like you've got your thumb on the end of the hose. Medications are a little more challenging for that because we can reduce kind of that um, bladder muscle activity, but the medicines often don't do a heck of a lot for the sphincter muscles. And so you end up a lot of times needing to do catheters and things like that. Um, Obviously, the catheters are a last resort, but when people start getting urinary retention and urinary tract infections, you got to do something. So we often end up relying on urology quite a lot for the more complicated bladder dysfunction. Um, a lot of sensory disturbances, burning, tingling, itching, pins and needles, tight squeezing sensations like the MS hug. There's no magic answer necessarily to how we manage these symptoms. It really, to a large degree, comes down to here, try this and see what works with the usual kind of things that you would use to treat, neuropathic pain for somebody with diabetic neuropathy, burning, tingling, and whatnot. Antidepressant medications, seizure medications, gabapentin, pregabalin. Um, the one kind of specific instance would be when people have these band-like sensations. Carbamazepine usually works quite well for that. But otherwise, it's a little bit of a game of here, try this and see what happens. Frustrating for everybody involved. Gait impairment is the other big one. The one really medication that we have here is dalfampridine, which basically has been approved for treating walking speed in people with MS. It basically speeds conduction along the nerves so people can walk a little faster. Um, Use of the assistive devices is the big thing, and then rehab, rehab, rehab. Um, you know, I don't have a pill to give you. I don't have an infusion to give you that's going to make your walking and balance better. In fact, most of the stuff I prescribe you to treat your symptoms will probably make balance worse. Um, and so when it comes to gait impairment, we really rely on the rehab specialist, physical occupational therapy. Um, People are often resistant to the idea of using some kind of assistive device to walk, cane, walker, crutch, wheelchair, whatever it may be. Um, you know, what I try to get folks with MS to see is that these things are tools to allow you to do more. If you're expending less of your energy to keep yourself upright and keep yourself from falling over, you can do more with your day. If you're slogging it trying to make it all the way across Disney World, you're going to have a terrible time. If you just use the scooter at Disney, you're going to have a lot more fun and be able to do a lot more. Um, Spasms and spasticity tend to be a big one as well. So people will often have a lot of increased tone in their muscles. They can also get spasms. The simplest solution, and in many cases the best solution, is just keeping things loose and moving them with stretching and yoga. Um, I have this one patient who's had MS for 35 years or something like that, um, and is, bed nearly bedbound, but gets around with a power chair. And her legs are more limber than mine. And that's because she and her sister, like every day when she gets up in the morning, spend like 30 minutes just stretching and moving her legs and keeping that range of motion in there. And because they've been so religious about doing that for the last 30 years, she doesn't really have a lot of problems with muscle spasms and spasticity. Um, we do use muscle relaxers, baclofen, tizanidine, the usual stuff that you think about when it comes to muscle relaxers. They're of variable efficacy, but usually I will use baclofen, tends to be the most effective. For people that have these really severe kind of extensor spasms where their limb will stiffen straight out, or they have flexor spasms where it flexes in and gets stuck, those can be quite painful. Carbamazepine is generally pretty effective for dealing with that. And then in more severe cases, we'll have intrathecal baclofen, so you can get a baclofen pump that doses the baclofen directly into the spinal fluid. The nice thing with that is that you don't have to worry so much about the sedating effects of the medication, but it's an implanted device that has to be refilled and it has a battery that eventually dies. So it eventually needs to be replaced. The other hot topic that tends to come up a lot is diet. Um, these are just a handful of the diets that you'll find out there when you start Googling diets for multiple sclerosis. They've done some studies on these, and generally speaking, there's not been much evidence to suggest that there's any particular diet or supplement that is good or bad for that matter for MS. Um, Most of these diets, if you really get into it, are basically getting away from processed food, eating more fruits and vegetables and lean meats. And so people feel better when they eat less garbage. And I'm not opposed to that in any way, shape, or form. But is there one of these that's better than the other? Not really. Um, at the end of the day, what we tell people is if it's good for heart health, it's good for brain health. Everything that we know about, dementia, stroke, any kind of neurodegenerative condition like Parkinson's, is that cardiovascular risk factors, high blood pressure, diabetes, tobacco use, high cholesterol, those all increase risk of any kind of bad brain disease. And so if it's good for your heart, it's good for your brain, have at it. Goes for exercise as well. And then general health. So, what we do know is that people who have MS who have other medical conditions, the usual suspects, high blood pressure, diabetes, high cholesterol, take your pick. Doesn't really matter which one it is. Um, People who have comorbid medical conditions with their MS have increased mortality. They have a higher risk of having relapses of their MS. They have a higher risk of developing progressive MS and more likely to have incomplete recovery from their relapses and have higher disability from their MS. And that's even if, like, so you get MS, we diagnose you a year later with hypertension and you take your ACE inhibitor and your blood pressure is well controlled. Even if that comorbid medical condition is well controlled, it has an impact on your MS over the long term. Tobacco use is a big one. Just like that list up there with comorbid medical conditions, tobacco use increases all of the bad things associated with MS, like progressive MS, incomplete recovery of relapses, increased mortality, all of that. So what I tell everybody is, yeah, you have the MS, have MS, but really you have all these other things that you need to be following up on with a primary care physician. And if you don't have one, you need to have one and you need to see them on a regular basis because now it's extra important that you have those health maintenance things done, the cancer screenings, the blood pressure screenings, checking an A1C, checking lipids, all of those sorts of things to make sure that we're trying to minimize the number of other medical conditions you collect along the way because most people with MS, when they're diagnosed or in their 20s and 30s, they think they're invincible and they don't need a primary care doctor. Um, and so I try very hard to encourage them to establish care with somebody somewhere, anywhere, and please go see them. So kind of for y'all's information, I'm concerned I've got that my patient might have MS. Now what? First off, don't panic. And second off, try not to let them panic. They will, but that's just going to happen anyways. So kind of what are we doing when we're evaluating somebody who might have MS? The first thing is just rule out other things. If you go read down the differential diagnosis of MS, it's basically any medical condition. The big ones, though, are going to be rheumatologic conditions. Pick your rheumatologic disease, lupus, rheumatoid arthritis, Sjogren's, the list is long. Infectious processes can also mimic MS. The big ones would be things like syphilis and HIV. And then nutritional deficiencies. I had this woman several years ago who I was just absolutely convinced had primary progressive MS, but I checked her B12 and it was undetectable. I threw a bunch of B12 at her. It was still undetectable, and it finally turned out that she just had pernicious anemia and could not absorb B12, and that's why she had neurological symptoms. And if you actually go back to the kind of first set of diagnostic criteria for MS published in 65, I thought Dr. Schumacher made a nice point here that the familiar list of common symptoms and signs of the disease is of limited value since these may be caused by other diseases or be absent in MS. Basically to say, yes, you can have the symptoms of MS, but you don't have to have MS because you can have those symptoms for a variety of other reasons. We're going to get MRIs on pretty much everybody. If possible, we like seeing those with contrast as long as there's no contraindication to people getting contrast. The brain is really non-negotiable. We got to have that. The cervical spine, if they haven't already had it, I'm going to get it when they come to see me. And for the providers on the call, if you're trying to figure out how to get it approved, you can drop that ICD-10 code in, and it usually takes care of it for the prior authorization. CNS demyelination is my favorite. Just put that in, they'll let me do whatever I want. and then finding, where do I send this person next? The MS specialists are few and far between, as you can see from this map of, it's basically centered on the major cities. In Alabama, we have a few groups who are MS specialists. That's us here at UAB. Also in Birmingham, you have Dr. Reiser at Alabama Neurology Associates. You have Dr. Kilgo at South Alabama and Dr. Minto, who's over on the eastern shore of Mobile Bay. Arkansas, you've got UAMS. Louisiana, you've got a few areas, but mostly centered in New Orleans. And then Mississippi is mostly University of Mississippi and Jackson more broadly. Not to discount, though, your just general community neurologists who may be more available to you than and closer to you than us. Um, you know, the patients that I see who've been seen by the community neurologists throughout Alabama and most of Mississippi, by and large, are doing the right things and doing them well. Um, Rarely do I have something to say about that maybe wasn't right or wasn't the best way of addressing it. I may have a slightly different approach than they do, but it's only because I have a different opinion. It's not because I'm right or have a better idea of how to do things. So I think also relying on your local community neurologists as a first point of contact is probably, you know, not a bad idea in many cases. And if it turns out to be something more complex than they're comfortable with handling, and then, they can easily hand that off to, one of these specialist places, whether that's an academic center or not. Um, and then last but not, just resources for your patients and for you as healthcare providers as well. The MS Society has a really great website with a lot of just kind of good information about what is MS, how do we treat it. It also has good provider resources for referrals. So they have a listing of folks who've basically, shown an interest in MS and have, proven themselves to have the capability of managing folks with MS. And then the MS Association of America also has some good resources. I generally direct patients to the MS Society's website, but the MSAA also has some really good resources. And last but not least, it's a team sport. You know, Patients with MS have a variety of problems and issues, not all of which can be handled by the neurologist. And so we end up referring out for quite a lot of things, whether that's therapy, occupational, physical, speech therapy. Urology is probably one of our bigger ones to deal with the complex bladder issues. For people who have kind of more complex um, mobility needs, physical medicine and rehab is a huge help for us. Mental health conditions are more common in the MS population, regardless of the level of disability. So depression, anxiety, take your pick. So psychiatry sometimes getting involved. Social workers, MS is an expensive and complex disease, and navigating the system is not easy. And so social workers often are a huge, huge part of helping our patients get what and where they need. Um, and then honestly, the primary care physician is probably the biggest piece of this puzzle because they're the ones who are often going to end up kind of being the point of contact for a lot of these folks with MS. Um, and I think that's all I've got for y'all today. I'm happy to take any questions that you have um, and provide any insights if there's any there. I even kept it kind of on time. Nobody, I answered all the questions. Fantastic.
This is great content, and we really appreciate it. I really am grateful that you dove into some of the elements of how to overcome this or treat, well, not overcome, but treat the symptoms as they're going along, and things to look for, and things we can do, as you said, to kind of hedge off the corners of MS. And so I think that's very helpful for everyone being on, and those that we deal with on a daily basis, whether they're friends or family or patients. Being able to have some helpful tips for them to guide them through this process, I think is very helpful. Any questions for Dr. Jones? I haven't heard any or seen any in the chat box. Okay. Well, thank you for being on. We appreciate all your work at UAB, and thank you for your being here with us to share multiple sclerosis tips and strategies, and just a little bit more about the disease and how we can help those in our lives. We appreciate it, and thank you all for being on the call today.
Absolutely. Thank you all for the invitation.
Thank you.